much like many experienced oncology nurses, I learned how to do IVs with palpation. I got really good at it. So I thought, there's no way I need this ultrasound. We know now that our patients are sicker. There are more DIVA patients or difficult IV access patients, and we've got to put the patient first, and we've got to use the best technology. So I've really come full circle with my thinking. And in fact, now it's like driving a car without a seatbelt.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with MiKaela Olsen, Clinical Program Director of Oncology at the Johns Hopkins Health System, about ultrasound-guided IV placements in patients with cancer. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us again today, MiKaela.
Thank you so much for having me.
So to start things off with today's episode, let's start with a little background. Can you tell us about the history of ultrasound guidance for peripheral IV placements, and why is that practice becoming more standard?
Some of you may or may not know this, but over 1 billion short peripheral IVs are inserted worldwide annually. And when I say short, I'm usually talking about a peripheral IV that's an inch or less. One systematic review and meta-analysis actually reported a failure rate of up to 30% on the first attempt when doing an IV, a peripheral IV cannulation. And peripheral IV complication rates are really significant, including infection and infiltration and extravasation. And we're giving a lot of drugs in oncology that are vesicants and irritants. Failure is not uncommon with these IVs, as I said, and hospitalized patients can have repeated IV attempts, lots of sticks, and as many as 50% of those short peripheral IVs, once they're placed in hospitals, can fail within that first 24 hours. So there's a lot of literature out there about this. Many hospitals have started DIVA teams, and DIVA means difficult IV access, and those teams are used to escalate these difficult sticks to. And they can be very helpful, especially if they're trained in ultrasound. But I think the reason we're talking about this today is I'm hoping to really get everybody jazzed about new technology that can help provide care for our patients that's innovative and also help us reduce the number of sticks and reduce that chair time and et cetera. The other thing I wanted to say is the repeated access, trying to get these IVs in our patients, not only leads to suboptimal clinical and economic outcomes, it can be very traumatic for patients. And I've had patients tell me that they have PTSD from getting stuck so many times, and they fear coming in for their appointment because of those sticks and who's going to be on and are they going to be able to get my IV, et cetera. And so there's avoidable harm here that we need to pay attention to.
I think that's so important. And I'm excited to hear about, as you mentioned, as you said, technology that can help us do this work better. And even from the nurse's perspective, it's hard when you're not confident in your IV starting skills, or just maybe is not something that you ever really come to be, you're not the go-to person on the unit to start IVs. And so how helpful will it be to have technology that could help us not only be more successful, but feel more confident when we're doing that task for our patients as well?
Exactly. And I will say, I was years ago, before I learned how to do ultrasound-guided IVs, I was a little skeptical because my journey is much like many experienced oncology nurses. I learned how to do IVs with palpation. I got really good at it. And actually during Desert Storm, when I was an Army nurse, they stationed me in Texas at a big Army base, and I worked on a pediatric oncology unit. And so I thought, there's no way I need this ultrasound because I can do this. I can palpate anything. But we know now that our patients are sicker. There are more DIVA patients or difficult IV access patients, and that's because there's more diabetes. We have more obesity. We have IV drug abuse patients that have sclerosed veins or damaged veins. And we've got to put the patient first, and we've got to use the best technology. And palpation alone is not actually the optimal way to always do it unless you can see a really nice vein on the surface. So I've really come full circle with my thinking. And in fact, now it's like driving a car without a seatbelt or an airbag. We wouldn't think of that anymore. So I always, even if I see the vein, I'm going to bring my ultrasound so I can do a good assessment.
Well, before we get into the details of the ultrasound, let's just talk about peripheral IVs and when are they appropriate? What kinds of cancer therapies can we and should we be administering through a peripheral access?
Through any peripheral access or through one with an ultrasound-guided?
Well, let's start with just in general, peripheral access.
So we have some good guidance in the Oncology Nursing Society Chemotherapy and Immunotherapy Guidelines book. And in terms of what we consider a vesicant and what drugs are irritants, and the detail of that is in the guidelines. There are also sources like Lexicomp and other sources where you can look up to see if a drug is a vesicant or an irritant. And I would say that in general, in oncology, where we sort of have a national guideline that says we don't give peripheral chemotherapy vesicants continuously through a peripheral IV because the risk of extravasation when something's running continuous, like adriamycin or another one of those vesicant drugs, is high. And the IV can come out of the vein and then we can have an extravasation that can be undetected for many hours. So in general, continuous infusion vesicant chemo is always given through a central line. Many other things can be given peripherally, but many of the drugs we give are irritants. And if we're giving a short-term vesicant where we're doing a mini bag or an IV push, we've got to stay with our patient during the administration. We've got to use fluids to dilute them while we're administering them. And we call that IV sidearm technique. And we need to be checking our blood return frequently. And again, those specific recommendations are in the guidelines for everyone to look at.
So what are the advantages of using ultrasound guidance for placing these peripheral IVs?
I think there's still some hesitation with the use of ultrasound-guided IVs because people are worried that they're going to be accessing a vein that's deeper than a surface vein. And that means that they might not detect extravasation or infiltration. So I'm going to talk a little bit about, as we go through this podcast, strategies for ensuring that your team has been trained appropriately to make sure that you have a good ultrasound-guided IV so that you do have the catheter seated in that vein enough that you are confident that that's going to be a good IV. I think it's very important to think about placement and how it's placed and having trained clinicians that do this. As I mentioned before, the benefits of ultrasound-guided IVs are that they can reduce cost, they reduce clinical time, reduce pain and sticks for our patients, many of whom can actually, be so fearful that they're asking for a central line. And we know that central lines are not without complications either. And in some cases, our patients can do well with peripheral IVs, but we need to stop the multiple sticks and we need to get our patients IVs in quicker and with technology to allow us to see that catheter placement and know that it's successfully in that vein and we have a good blood return.
What are some of the complications that can occur that nurses need to be aware of and just keep into consideration when placing peripheral IVs using ultrasound guidance?
The benefit of having an ultrasound, it allows you to see through. You're no longer sort of bound by, can I feel it? Are there skin discolorations or skin colors that are affecting my ability to see the vein clearly? You don't have to worry about any of that. Is there edema? Is there lots of tissue? You can actually directly visualize the veins to assess not only the health of the vein, but some of the complications that could be there, like a thrombus in the vein or sclerosis or tortuous anatomy, arteries, nerve bundles. Those are things that you can now see with your machine. Obviously, complications can include puncturing into an artery, and that's why the training is so important because arteries are generally pretty easy to see on the ultrasound, and we want to stay away from those. You can also accidentally put that needle into a nerve bundle, and you know that when you are placing an IV, because many of us have either done phlebotomy on a patient or put an IV in, and then the patient cried out that they felt a sharp electric-like pain. And that means you've touched on a nerve. So it's really important that nurses are trained in how to see things on the ultrasound. They recognize those areas that they need to avoid and recognize what a good, healthy vein looks like to prevent complications such as arterial puncture, hitting a nerve, or even hitting a bone. Sometimes the bone is nearby and you can hit that and cause pain. I think the biggest complication, though, related to ultrasound-guided IVs is not knowing how much distance you have between the top of the skin down into that vein, and then making sure that your catheter is embedded into that vein. At least more than 50% of the catheter needs to be going down the vein and not just in the tissue. Because if you've got the tip of the catheter going down and it's just barely in the vein, then the patient moves and that IV will infiltrate or come out. So that's the problem. We don't really know. We hope that that doesn't happen with our short peripherals because they're more superficial. But with ultrasound-guided IVs, I think that's probably people's worst fear, is that they're not going to get it in far enough and then we're going to have an infiltration. But with proper training and proper equipment, this can be mitigated.
So kind of keeping with that, in terms of the proper training, what are some of the most important considerations that nurses should keep in mind to ensure that peripheral IVs they place with ultrasound work well, they function, and that the patient has a good outcome from that placement?
Having really good trainers that do this all the time. The literature shows that just like any skill, it's going to take quite a few sticks for you to be really proficient at this. I like to say that even those of us that are really good at palpation, we might not do as well with this skill. It takes hand-eye coordination, and it takes kind of an abstract eye when you're looking at that ultrasound. And some people have a hard time visualizing the anatomy on the ultrasound. So practice makes perfect. Having really good trainers that allow you to practice on what we call a phantom, or it's like a slab that you can practice on that really mimics what a real vein looks like in a patient. And lots of practice on that first, and then going to do your insertions on the patient with somebody that's a super user or trainer that can really help you troubleshoot through the nuances of learning this skill. It's usually the case that after people have done about 20 of them, they really their success rate just skyrockets, and you can achieve almost 100% success rate after you've done a lot of these, because you know how to maneuver through those veins and get these IVs in. Remember that doing ultrasound-guided IV really does require a longer peripheral IV. So generally speaking, we use 1.8 inches or greater for our ultrasound-guided IVs. We call them long peripheral IVs because the short peripheral IVs will not be long enough to go through the tissue and then get enough of it seated into that vein to decrease the risk of infiltration. And then if we get enough catheter into the vein, it really has been proven with lots of literature studies to improve the longevity of the device. This will help prevent dislodgement, infiltration, and extravasation.
Now, you referenced them earlier, but certainly ONS has guidelines, as well as our colleagues at the Infusion Nurses Society have guidelines as well. What do they say about ultrasound-guided peripheral IVs?
I think that all of these organizations are now excited about this new technology coming and definitely focused a lot on training and competency and making sure that that's all in place so that we do this safely, because there is a risk of patient harm, just like there is with a regular IV, if people are not skilled. And I really like to focus on that, because you've now got this really great machine that can guide you, but now you are more near other anatomical things like arteries and nerves and nerve bundles that you could harm. So having really great training is really important. And in my organization, we've started a lot of ultrasound guided training programs, and we're having really good success. But again, I do see more failures and problems when the staff are less skilled. So we need to support our staff through the period of time where they're still learning and make sure they understand the principles of catheter to vein ratio, catheter length, those kinds of things that are so important. INS 2024 standards say provide ultrasound guided peripheral intravenous catheter services, including the training to infusion clinic clinicians to improve patient satisfaction and to reduce infusion delays in outpatient procedure centers. I love that. And I know that that is a Category 5 recommendation from INS. I think it's a great one because it's in our outpatient infusion clinics where we're doing a lot of IVs on a daily basis. And one IV that doesn't go in or that infiltrates can cause a lot of harm to the patient and a lot of delays in care. Chair time is affected, et cetera. We have information in our ONS vascular access guidelines as well that support this. INS also has another standard, which I think is really important. And that is that when we're doing this, that we not only are properly trained, but we use sterile single-use gel packets. I like to point that out with this skill because there's a lot of bottles of gel around and we want to make sure people are putting IVs in aseptically and not causing a bloodstream infection. So using a sterile single-use gel packet when you're ready to do the procedure after you've done the antisepsis, which is usually chlorhexidine, then you use your sterile gel and then you need a sterile barrier over the probe so that you can protect the probe from contamination and protect the patient from contamination of the probe. So those are really important things. Your gel is to help transduce. And then they also have recommendations about choosing the right needles, choosing, your equipment, things like that. And the INS standards say that we should establish comprehensive ultrasound-guided training programs that support the clinicians from novice to expert on that continuum. And that's kind of what I was talking about earlier. Really, you can't just take someone to a class and then let them out. They're going to be a novice for a while. It's a hard skill in the beginning for some people, and everyone needs a lot of support.
Absolutely. And training's certainly important, as you've mentioned, and the guideline support. Going to a class one time is not enough. And also just getting the equipment and having it available on the unit without the training is also not enough. And so both of those things together plus repetition is really the key to success for this. Let's talk a little bit about your experience. So you have had experience establishing an ultrasound-guided IV team. How did you set that training program up, and what parts of that program helped the nurses be successful with that skill?
I think that the most important part of that is having a really good didactic session where nurses come in and they learn reminders about the anatomy. Where are these veins? Where are the best veins to cannulate when you're using ultrasound? And we like to avoid the veins above the anacube for regular long peripheral IVs that we insert with ultrasound because we want to preserve those veins up higher for our PICC lines and midlines. So we want to teach to try to use the forearm. The cephalic vein in the forearm is a really excellent vein to choose. So those are the principles of how to use an ultrasound and how to safely access a vein, and where are your nerve bundles? Where are bones? Where are your arteries? Where is your, what we call the Mickey Mouse, where you have the two veins with the artery in the middle? That's not an area that you want a novice nurse going into because they're not going to potentially be able to prevent getting into that artery. So lots of really important information has to be included in the course, and lots of practice time, lots of classroom practice time, and then going out to do the first attempts on patients with a skilled trainer that can guide them through the process. And I love doing that because I love when a nurse gets their first couple and you can see their confidence just shoot up. And usually after about 10 successful, people get much more confident. We've had people drop out after the first few because they just feel so frustrated and they can't see things. So take them back to the classroom, do some more work with the phantom, and then go back out. And then once you can get over that little hump and get that confidence up, I see people just taking off. And oncology nurses love to have this skill. So back to your question, really good didactic, really good practice, and then out only with a skilled person that can stand there over your shoulder and guide you and help you. Those are just really important points.
What are your recommendations or some considerations in not only standing up the program, a training program as you described, but helping to maintain it over time and monitoring outcomes of the result of these type of training programs?
We really need to monitor the outcomes of these programs. We need to make sure that we're not increasing infiltrations or extravasations and putting our patients at risk. We need to make sure that staff are using the proper equipment, and we need to monitor staff success rates. I think that's really important because if someone did their designated amount per your institutional policy and now they're on their own, but they're consistently only getting about 50% of them, then that puts the patients at risk. So we need to monitor outcomes. We need to continue to provide support until that person gets their success rates up, ensuring that staff are really very careful when they place them to visualize that that catheter is fully in the vein. There are some strategies you can use with your probe during the insertion to make sure that you can turn the probe longitudinally, and then you can see that your catheter is clearly in the vein. Then you can do a little flush and you can see that. And that gives you confidence that I've got enough catheter in there and my vein has a wonderful blood return.
Well, MiKaela, you clearly specialize and have lots of expertise in vascular access using ultrasound-guided placement for the peripheral IVs. So what do you enjoy most about having this skill? And do you have any patient success stories that you could share? And also, I'm just kind of curious, how do the patients react when this new skill is being sort of rolled out and taught? Any recommendations on how to sort of reassure patients as this new skill is being taught?
I love to go into a room where, I don't mean to say this way, but like there's been failures, the patient is fearful, and I go in and I explain what I'm going to do. They're usually kind of impressed with the machine and the technology. And I explain that we're not able to get it without being able to see better. So I'm going to use my machine so that I can see better. And almost every time after I'm done, the patient is like, wow, are you done? Because the nice thing about ultrasound-guided IV, and until some of you do this, so you know what I mean, but it's the initial little puncture that hurts the patient. But unlike when we do it blindly and maybe we don't get it right in the vein and we're having to dig around and reposition ourselves and get into that vein, we're not doing that with ultrasound because you're going to go into the vein and then you're starting to do the threading and you're pulling your probe up as you go to get that catheter in the vein. The patient doesn't feel that part. So they often comment about how they barely felt it and they can't believe it's over. And what will happen, and I'll warn you all, is that your patient will love it. And then they will say to other patients, and they will tell that, when they come back in, oh, I only can do this with the ultrasound. So you got to be able to ready to support that because it's a great program and patients and families know that. And so it will kind of blow up, if you will, in terms of the use of it and people asking for it, which is wonderful, right?
Right. That's kind of the whole point, is to be able to do it successfully and decrease harm and improve their experience.
And then another thing I want to say in response to your question is that I've had a lot of success placing long peripheral ultrasound-guided IVs in patients getting things like Taxotere and Gemzar. We know those are really significant irritants. They can be. And in these little short veins that are superficial, maybe on the hand and not in a deeper vein, they can have a lot of burning and irritation during the treatment. And with Gemzar, that's a chemotherapy drug that you don't want to extend the duration of because it can increase the risk of myelosuppression if you give it over longer periods of time than what is prescribed. And so we want to give our drugs on time according to the prescribed time, but we also know that our patients will have a lot of pain and burning. So we're spending a lot of time helping our patient, comforting them, putting warm packs, trying to dilute it a little bit more, or even replacing the IV. And then maybe we even say to the physician, this patient had a lot of trouble, we need a central line. But I've had really great success bringing patients through those kinds of treatments by having trained clinicians that are really good at ultrasound-guided IVs, put that IV in for them and in a deeper vein that has better flow so that it's kind of magic how the phlebitis, the irritation goes away when you use a deeper vein. But again, the key is properly trained staff that have the skill that really get that catheter in correctly.
Absolutely. Well, MiKaela, thank you as always for your time on the podcast. I think it's a very important and exciting topic, and I'm sure our listeners will come away from this, if they don't already have one, wanting to explore how they can implement an ultrasound-guided IV team, or at least access to the training and the equipment in their own sites of care. As we reach the end of our episode, we like to always run through a few quick fire questions to help summarize some of the topics that we've covered today. So to start that off, How do you think healthcare professionals should evaluate their hidden or their implicit bias when it comes to using ultrasound-guided IV placements with their patients with cancer?
I've been at some conferences recently, some vascular access conferences, where they talk about this in relation to vascular access, and that skin color and other things can affect not only our success rates, but our bias. And so it's really important that you use this technology because it sort of takes all that away, right? We are looking at every individual the same way. We're looking at internally at their veins and arteries, and we're able to hopefully be more successful with this skill and kind of get around that a little bit, if you will, and see what the health of the patient's veins are. And that's the most important thing with providing vascular access to our patients.
What are some common misconceptions about ultrasound-guided IV placements?
That they're all going to infiltrate. And that's why I really focused during this podcast on how to be successful with that and how to make sure that our IVs that we put in with ultrasound stay in and have longevity and have a good blood return. All the principles that you know when you administer chemotherapy or any parenteral drugs in terms of making sure your IV is patent and that you have a good blood return still apply. You may not be able to see on the surface a little bit of swelling as quickly, but you still can assess that IV for patency and make sure it's free flowing and all the same things that you do for all of your other IVs. So that's important. And then I think that another thing that people think is that, oh, it's too much. I don't have anybody here that has ever done this. How am I going to start a training program? But one of the things you can do is you can partner with manufacturers who often have very skilled clinicians who can assist with the didactic and the hands-on education. And that can help you grow your own group of super users and trainers. And that's actually how I started. These resources are often included in the purchase of equipment, whether it be your long peripheral IVs or your ultrasounds. So partner with these manufacturers, use those resources and get your program up and running.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think the most important thing that's not discussed is how much this is causing harm potentially and discomfort for our patients and how much anxiety that vascular access produces. And, the answer is not to just put a central line in everybody because there are risks of bloodstream infection and thrombus, major thrombus, and lots of other things with central lines. So you have to get the right device in at the right time. And organizations should have algorithms like we do. And I'm sure other organizations, lots of places have these really nice algorithms that can help guide you. Do we need a peripheral? Does this patient have to have a central? Could we use a long peripheral ultrasound-guided IV? These are questions that you can lay out. And I think that you can successfully treat cancer patients with ultrasound-guided IVs. I've had quite a few breast patients and lymphoma patients that we took through their entire curative treatment without having to get a central line. And with one stick for the ultrasound-guided IV at the time of their chemotherapy. And again, that's a program that's been in place for quite a while where we've got really skilled people. So you have to kind of work toward that. But I think that we can't underestimate how this affects our patients. And this is becoming the standard of care. Just like years ago, central lines were always placed by providers using anatomy and palpation and landmarks. That's no longer the case. The national recommendations recommend ultrasound for central line placement. It's not always being done yet, but we're moving in that direction. And it's going to be the same with ultrasound-guided IVs. They are becoming more and more the standard of care. Our emergency room colleagues are probably the most successful with this. There are lots of published studies in EDs showing wonderful success, less wait times, improved patient satisfaction and staff satisfaction by learning this skill and having it. And I didn't mention, but I love using an ultrasound for somebody that you're just doing phlebotomy on and all their AC veins and their antecubital veins are kind of shot and they've been stuck a lot of times. Put an ultrasound probe on there and find a good healthy vein, and one stick with the little butterfly needle to draw their blood is another strategy that you can use with your ultrasound.
What additional training or education do oncology nurses need to stay current on this topic?
I think they need to document the number that they're doing on an ongoing basis to prove that they're doing the skill enough to stay competent. It's like anything. If you stop doing it, you're going to get rusty. It's just like regular peripheral IVs. We need to use that skill and keep it going. They need to stay up on the literature when things change, when equipment changes, things like that. Ultrasounds change or there's newer technology. All that's important. And monitor their outcomes and the patient outcomes, which we talked about a little bit earlier. And one thing that I love to tell people is that we need to stop saying to our patients, and this is kind of my measure of success when we're no longer kind of putting this on the patient. We're not saying, you have difficult veins, your veins roll, you're not drinking enough. That's not okay anymore. We've got to take responsibility and use technology to do this more successfully. So if you're just sort of thinking about this and you haven't done it yet, start thinking about it. And I hope that I've given you a little bit of wet your whistle for trying to look into this and do this because it is coming.
Absolutely. And finally, what additional resources for maybe patients or other providers would you recommend if they want to learn more?
It's amazing how many videos there are on the internet that talk about the benefits of ultrasound-guided IVs and actual videos showing you how to do it. I, obviously would need to vet some of those to be able to recommend any of them, but there's more and more really well done published literature out there showing randomized clinical trials and meta-analysis showing the benefit of this technology. So I would say go to the literature, look at our national standards like INS and ONS and other tools that are out there. And as I said, manufacturers have lots of great technology on their websites as well.
Well, MiKaela, as always, it's been great talking with you. And thank you again for coming back to the podcast to share some more wonderful information with our listeners today. Do you have any final comments to share?
I think just to remember that the use of ultrasound as a tool for oncology nurses in both inpatient and ambulatory centers has really massive potential. And we need to be moving in that direction for our cancer patients. We need to use these tools that are available to us to provide evidence-based care that's not only compassionate, but patient-centered. This really is a game changer. And I told you in the beginning, but I've come full circle with, I love to palpate and get my IVs in, and I had a pretty good success rate. But over time, I noticed that our patients were changing a bit and they're sicker, especially in cancer patients are living longer and they've had many more years of injury to those veins. Vessel health is different now and it may not be as good. So imagine if a cancer patient started out their journey by having this technology, how much less vein damage and trauma that patient would go through. And then I hope that this podcast inspires you all to start your own programs in your organizations, because as I said before, this technology is here to stay. It's becoming standard and it's really the right thing to do.
Very well said. Thank you so much for your time, MiKaela.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.